Welcome, everyone. Thank you so much for joining us for our webinar, Getting the Care You Want at the End of Life. This event is co-hosted by End of Life Choices New York and Death with Dignity Albany. My name is Lillian Maron, and I am the Director of Outreach and Education at End of Life Choices New York. End of Life Choices New York is a nonprofit with a mission to improve end-of-life care, expand end-of-life options, and promote healthcare equity at the end of life. And we do this in 3 ways. The first is by pursuing legal and legislative reform to expand end-of-life options, including medical aid in dying, and to ensure a patient's right to a peaceful death. We also educate the public and healthcare professionals on end-of-life issues, and we provide free counseling and support to people who are preparing advance directives, caring for a loved one, or who are approaching the end of life themselves. Bonnie, tell us a little bit about Death with Dignity Albany.
Thank you, Lillian. Welcome, everyone. In case you're not familiar with Death with Dignity Albany, we are an independent, volunteer-run organization that was founded in 2015, and we're obviously based in the Capital Region, and we have a dual mission. We provide a forum for discussion and for learning about a wide variety of end-of-life issues. And we also advocate for the passage of medical aid in dying legislation in New York State. We are very pleased to join forces with End of Life Choices New York today to bring you this program and to present this, our speaker, David Levin. As Lillian will tell you in more detail, I expect, David has been a courageous and indefatigable leader in many end-of-life issues, broad range, and just last week had a letter to the editor published in the New York Times, one of many he's had published around the country over the years. Personally, I'm particularly pleased to join this collaboration today because David has been a very generous mentor to me personally in my own journey in this field, and I'm very grateful for his support and encouragement. So now I turn it back to Lillian. Enjoy the program.
Thank you, Bonnie. So before jumping in to give you even more information about our wonderful speaker, I just wanted to go over some logistics. So after the talk, there will be time to answer your questions. To ask a question, feel free to type it into the Q&A box at any time. You can find it if you're using a computer on the bottom of your screen, and it should say Q&A, and we'll answer those at the end. We're recording this talk, and we will be sharing a link to the recording with all of you once it's available. So without further ado, let me introduce our speaker, David Levin. David was the Executive Director of End of Life Choices New York from 2002 until 2016, a leading advocate for patients and an expert on advanced care planning, patient rights, palliative care, and end-of-life issues. David has played a key role in having legislation introduced and enacted in New York to improve pain, palliative, and end-of-life care, including the Palliative Care Information Act. David lectures frequently to diverse professional groups, students, and the general public, and is a regular guest lecturer at the College of New Rochelle School of Nursing and Fordham Graduate School of Social Service. A graduate of the University of Rochester and Syracuse University College of Law, he is the recipient of numerous awards, including the Public Interest Law Award of the New York State Bar Association Public Interest Law Committee. We're so excited, David, to have you speak with us, so I turn it over to you.
Thank you very much, Lillian, for the kind introduction, and thanks very much, Bonnie, for your very kind remarks. I'm so delighted to be here with all of you this afternoon. And just by further way of introduction, I am a graduate of Syracuse Law School with Joe Biden. He was a classmate, just to show you how old I am. Beyond that, in terms of my career, I've always done public interest work, seeking justice for poor people as a legal services lawyer for the poor for 10 years in Rochester, justice for prisoners as the executive director of Prisoners Legal Services of New York for 20 years, and now for the past 19 years, as Lillian mentioned, working with End of Life Choices New York, seeking justice for patients. And the issues we're going to talk about today are really about health justice. And too many people at the end of their lives, and even before that, are not getting the kind of health justice they deserve, the kind of health care that they really are entitled to, the kind of good quality of care that they should be provided throughout their lives and at the end of their lives. So we're going to discuss a range of issues this afternoon, which I hope might be helpful to some of you at least, in terms of how you plan ahead for the end of your lives and in working with loved ones as well as your healthcare professionals. So in this country, we actually have a 100% mortality rate, just as we have throughout the world. I've done a lot of studying on this issue, and there seems to be no one who lives forever. And that, I think, is not going to change for the foreseeable future at the very least. So the only question really is how we're going to die and who's going to be making those decisions if we can no longer make healthcare decisions for ourselves. This gentleman seems to be dead, and yet the doctor is not maybe quite so sure. People have different types of living wills. We actually have one which you might want to look at on our website, which could be helpful to you, as well as many other documents on advanced care planning. So until very recently, people really died quite quickly of swift catastrophic illnesses. And now things have changed just over the last 60 or 70 years. People used to die pretty quickly of heart disease or strokes or cancer or other diseases. And now people are struggling for a long time and living longer with chronic diseases, but they're not necessarily living and dying better. And that's really unfortunate. But that happens for a variety of reasons, including the fact just of people living longer lives. But we have a real problem with end-of-life care and have had for a long time. If you look at what nurses think, they are really concerned about the end-of-life care in their own hospitals. And 58% of them, in a survey that was just conducted 2 years ago, said that their hospital's end-of-life care was really not good. So there's a lot that we need to do as individuals to ensure that we're going to get the kind of health care that we want at the end of our lives, whether it's in a hospital or nursing home setting or at home. So it's critically important to engage in a process of advanced care planning. And while most people talk about doing that, very few of us have, in fact, done so. I hope that most of you have, and I'm sure that many of you have, but probably some of you haven't. So we're going to talk about that for a few minutes because I think it's so critically important. And there may be some points which I'll make that you haven't yet thought of, even if you have engaged in some ways in discussing end-of-life wishes and your values with loved ones, and even if you might have appointed someone to be your healthcare agent. Again, people think it's important to talk with their doctor about their end-of-life wishes, and yet very few of them have had discussions with their healthcare professionals. And I understand that. Too many doctors and nurse practitioners don't raise the issue with patients, but patients need to be advocates for themselves and bring the topic up to their healthcare professionals. And it's really never too early to begin to engage in this process. All the leading cases involve young women where decisions had to be made by someone else when they lost decision-making capacity, either in their teens or their early 20s. Cases that went up to the United States Supreme Court, the Florida State Supreme Court, the New Jersey State Supreme Court, all involving young women. So think about what you need to do in order to engage in this process. And we're going to talk about a few things that you can do. Now, of course, we all want our healthcare wishes respected, right? And of course, we want them respected throughout our lives as well as at the end of our lives when we may lose decision-making capacity. And I will tell you that 70% of us will lose the ability to make our own healthcare decisions at the end of our lives. And that means someone else is going to have to be making most of those decisions. So engaging in this process of advanced care planning is really a gift to you and your loved ones, and it can avoid conflicts which otherwise frequently arise. So there are some things you can look at in terms of going through this process. The Conversation Project has a wonderful website and lots of good information and guidance. We have things on our website as well, as I mentioned, different advanced care planning forms. But the Conversation Project is really of tremendous benefit to many people who have gone to their website. So I want to tell you that when you think about what can happen, let's assume that you're now 80 years old and you have a mother who is 105 years old with advanced dementia and now has pneumonia. And you have a sibling. And the question now arises, what do we do with mom with the pneumonia? Do we treat her with antibiotics or not? Well, you and your loving sibling want to do the right thing for mom, but unfortunately, mom has never discussed her end of life wishes with you. And so neither of you have any idea as to what mom would want or not. And so your sibling might say, you know, mom has been a fighter all of her life. She's 105 years old. Let's just keep her going. She would want to get through this. And you might say, mom's been through enough. She has suffered so much. She has advanced dementia. She hasn't communicated in years. She's been bedridden. Well, who's right? We don't know who's right. And the reason we don't know is because mom has never communicated her wishes and her values. And so now you're going to be in a conflict situation with your loving sibling. And these conflicts, as I said earlier, arise all the time. And sometimes they are never completely resolved. So think about that if you haven't engaged yet in this process. Now, for those of you who have, hopefully you've chosen the right person who's going to be your healthcare agent. It's extremely important, though, that you think about it. It's got to be someone who's going to be comfortable making decisions, even if their own wishes are different than yours, and someone who's going to be able to speak up on your behalf and be a strong advocate. So for some people, you think, well, okay, I'm going to choose my spouse or my son. Well, your spouse may not be the right person because he may want to keep you alive no matter what and may not be able to carry out your wishes if you did not want to be kept alive under some or any or all circumstances after you lost decision-making capacity. So it may be important to try to choose someone else who will act as your healthcare agent. It might be a sibling, it might be another adult child. I made a mistake myself. Not in appointing my wife as my healthcare agent. She's the right person to be my agent because she's ready to get rid of me. No, but I did appoint someone as my alternate who was in denial himself about death and dying, who never completed a healthcare proxy himself until very recently. So about 2 or 3 years ago, I said to myself, you know, I think my daughter might be ready to be my alternate healthcare agent. So I had a discussion with her about things, and she agreed to be my alternate agent. So that's who my alternate agent is. So again, something you need to think about. And if you think maybe you've chosen the wrong person, then choose somebody else. And I'm sure the person who you initially chose to be your agent or alternate agent will be understanding. There is a law which does permit loved ones on a hierarchy basis to make healthcare decisions for someone who doesn't have a healthcare proxy, called the Family Healthcare Decisions Act, but it's really something you don't want to have to go to. And the reason is because if it's going to be used, it means that you probably have not had any of these discussions with loved ones. And it means that someone may be making decisions for you who you would not have chosen to make decisions had you appointed someone to be your healthcare agent. So it may be your spouse, even though you wouldn't have chosen your spouse, who's the top person on that hierarchy list. And the law is very complicated. Conflicts can easily arise. There is a very difficult decision-making standard for witholding or withdrawing life-sustaining treatment, etc. So again, this is all about having your wishes respected, no matter what they are. It doesn't matter. You may want to be kept alive forever, no matter what, as long as they can keep you, as long as you can be kept alive. Or under certain circumstances, after you've lost decision-making capacity, you may decide that life would no longer be worth living. So what needs to be discussed? Well, a whole range of things in terms of your conversation with loved ones as well as healthcare professionals. So think about what your diagnosis is, what your prognosis is, what your treatment options are, and what the side effects and risks may be, as well as the benefits. And what are your goals of care? Again, what makes life meaningful for you and what would not make life worth continuing to live? Okay, so if you've engaged in that process, and I hope that you will all do so, and speak with all of your loved ones, not just the person you appoint to be your healthcare agent and alternate and your doctor, but speak if you have other relatives who might be involved in your healthcare at a time when you've lost decision-making capacity, have a discussion with them as well. Okay, so one document which can really be helpful to people as they age and maybe within a year of dying, if you know you have a terminal illness or are very seriously ill, or you're in a nursing home or need nursing home care, or if you just want to express what your end of life wishes are with regard to life sustaining treatments, then you may want to complete what's called medical orders for life sustaining treatment, or MOLST, which is a document that's created between you or your healthcare agent, if you don't have decision-making capacity, or your surrogate, and your physician or nurse practitioner or physician assistant. And this is the only authorized form other than a out of hospital do not resuscitate order dealing with resuscitation. And you can say you want to be resuscitated or you don't want to. But I want to make it clear that with regard to resuscitation, if you think you might want to be resuscitated, depending upon your age and your condition, I will tell you that the vast majority of people do not survive CPR, cardiopulmonary resuscitation. Only 10 to 15% do, and a majority of those who even survive never leave the hospital setting. So the MOLST form, it's a pink form, 2 pages long. It's relatively easy to complete with your physician or nurse practitioner or physician assistant. And I'm showing you here the second page because it really encompasses a number of different items in addition to resuscitation. So there are treatment guidelines where you can say you want only comfort measures like palliative care essentially, or you want limited medical interventions or no limitations in medical interventions. Your choice as long as you have decision-making capacity, and if you don't, your healthcare agent or surrogate under the Family Healthcare Decisions Act can make these decisions for you. Either knowing what your wishes are, unlikely they will, or in your best interest. Then there are instructions for intubation and mechanical ventilation, where you can have, there's one of 3 checkoffs you can make, future hospitalizations, as well as artificially administered fluids and nutrition. There are 5 different choices that you can make. And you can put other things in the document as well. And then it's signed by the doctor or nurse practitioner, physician assistant. So again, who is this for? It's for patients who might need long-term care or who will die in the next year or likely to die within the next year, or want to avoid or receive any or all life-sustaining treatment. Again, totally up to you to receive hopefully the care that you want and are entitled to get, and not to receive care that you don't want. So the benefits of MOLST are that there's a required discussion, which is really important because most people don't have these types of discussions with their healthcare professionals. It does state your clearly stated preferences. It's a signed medical order. And therefore, of course, it's more likely to be respected than other things such as a living will. And actually, if you think about the Molst document compared to a living will, it's somewhat similar to many living wills, but it's very specific. And again, it's a medical order. Okay, let's talk about palliative care. And palliative care is something which can actually be provided at any time during the course of an illness. One does not have to be seriously ill or dying. And it's specialized medical care, generally provided to people with serious illnesses, but not always. And it's really focused on providing patients with relief from the symptoms of pain and stress of a serious illness, whatever the diagnosis. And the goal is to improve quality of life for both the patient and family. And it's often provided by an interdisciplinary team consisting of doctors, nurses, other specialists who work with the patients, as well as family members to provide an extra layer of support. And again, it's really appropriate at any age and at any time during the course of a serious illness. And it can, of course, be provided with curative treatment. Unfortunately, so many people still don't know about palliative care and what it entails, even doctors. And one of the reasons for that is that palliative care has really not been a practice which many doctors have been engaged in or even have learned about, except for in the last 20 years or so. But now virtually every hospital, certainly those with 300 beds or more, have a palliative care service, as do most smaller hospitals. So what does palliative care address? A whole range of different things which can be causing you to suffer, from physical symptoms to anxiety and depression, psychosocial issues, spiritual issues, and it can even address legal and other difficult issues. Um, so many people don't know about palliative care, as I mentioned, including even healthcare professionals. But once informed about palliative care, almost everyone agrees that it's important to provide it to people with a serious illness as well as to families. And it's important to have people educated about palliative care so that they can get the palliative care that they need if and when they're in a situation which is causing them to suffer. And still, even today, too many physicians either equate palliative care with hospice or end of life care, and some of them are resistant to believing otherwise. So, when it comes to palliative care, you may have to be a strong advocate for yourself, just as when it comes to you're being provided any other type of care that you may want and to which you're entitled. So in New York, we have a couple of laws relating to palliative care. One is the Palliative Care Access Act. And this law, which is now 10 years old, requires that hospitals and nursing homes and other home care agencies provide, have, policies and procedures in place to provide patients who may benefit from palliative care policies and procedures which will ensure that they will be provided palliative care if and when they might need it. Again, if you are in a hospital situation or a nursing home and you feel that you are not getting your pain well controlled or other symptoms, or you're suffering from anxiety or depression, or again from spiritual issues that you want to have discussed, you can ask for a palliative care consultation so that hopefully you'll be enrolled by the palliative care service, because these are people who are well trained when it comes to providing these types of services and are generally going to be able to provide higher quality services to you as a patient than most physicians in a hospital, hospitalists, and even nurses who always do a great job in providing wonderful care to patients, but don't necessarily know how to provide palliative care even when patients are entitled to receive it. So again, you may have to be a strong advocate for yourself when it comes to getting palliative care. And then we have a second law in New York, which I am very proud to have initiated and really fought to get enacted into law again 10 years ago. And it requires that if you are diagnosed with a terminal illness or condition, your attending healthcare practitioner must offer to provide you with information and counseling regarding palliative care and end-of-life options which are appropriate to you, and information regarding other appropriate treatment options if you want to initiate or continue life-sustaining treatments. Again, totally up to you if you want to get this information and counseling. Some people don't want to, and that's fine. But most of us would. And unfortunately, there's a disconnect still between healthcare professionals and patients, because most patients really do want to know what their diagnosis and prognosis is. And yet too many doctors still think that they don't want to know. And so they oftentimes don't provide this information and counseling to which patients really are entitled to. Doctors are required ethically to provide this information, but because historically they have so often not done so, that we work to get this law enacted. And so it is the law of New York State now. And so again, though, your doctor or nurse practitioner may not provide this information to you, which you're entitled to receive or offer to provide it to you. You may have to ask yourself, if you have an understanding that your condition is worsening, that you have a terminal disease, but it's not being discussed, you should talk with your healthcare practitioner. What is my diagnosis? What is my prognosis? What can you tell me about the risks and benefits of the current treatment I'm receiving? And what would you recommend that I do? And how long do you think I might survive with the disease that I have, with or without treatment? And what are the risks and benefits of whatever might be provided? Again, something which is required to be provided to patients under the Palliative Care Information Act. The risks and benefits of the various options that can be provided, and any other information that might be useful to the patient. Now, the information can be provided orally or in writing, but I can't imagine, frankly, that only information would be provided in writing. This is really something which has to be discussed, and maybe even more than once, assuming, again, that you want to have this discussion. Now, if for some reason at the point in time where you are terminally ill, you will also have lost decision-making capacity, and your healthcare agent now must make decisions for you, then the information and counseling must be provided to either your healthcare agent, or if you don't have one, to a healthcare surrogate under the Family Healthcare Decisions Act. So I'm going to talk a little bit more about hospice in a few minutes, but I do want to mention that hospice is required to be mentioned as one of the options for people under the Palliative Care Information Act, meaning that you have less than 6 months or less to live, because hospice is such a wonderful interdisciplinary program, similar to what's provided by palliative care, but only at the end of life. And it has a very high satisfaction rating. But I'm mentioning it now because I want you to realize that in New York, only about 30% of patients are enrolled in hospice at the time of their deaths, compared to about 50% nationally. And even when doctors do refer their patients to hospice, and by the way, you can make a self-referral, and the hospice doctor can then evaluate and assess you as to whether or not he or she thinks you are eligible for hospice. But only 1/3 of patients are enrolled for less than a month, or not only 1/3, 1/3 are enrolled for less than a month, and about 1/3 for just less than a week. So they're not going to benefit greatly from hospice care. You are really eligible within 6 months from the time you are diagnosed with a terminal disease from which you are likely to die during that time frame. And that's really the time to start thinking about and getting enrolled in hospice. Now, under the Palliative Care Information Act, I think last resort options can be discussed, but whether they're discussed or not, we'll talk about them here. Now, one thing which I didn't say and should have is that you are under control of your own health care. What that means is, very simply, that it's up to you to accept or reject treatment, no matter what treatment is offered to you at any time. You can accept treatment initially and then say, I don't want it anymore, whether it's dialysis, antibiotics, a feeding tube, pacemaker. This is entirely up to you as long as you have decision-making capacity. But sometimes patients are not receiving any life-sustaining treatments which are keeping them alive. And so at that point, and even if they are, they might choose the option because they feel that their lives are no longer worth living, that it's time for me to end my life. And so voluntarily stopping eating and drinking, which Judy Schwartz I know has presented on this issue, and probably some of you have heard her speak on it, is really a reasonable choice, especially when we don't have the option of medical aid in dying in New York, where people have to completely stop eating and drinking. And you have to have a consistent and desire to die, because it's not easy to completely stop drinking, and because you get very thirsty, as I understand it, after the first couple of days. But within a few days, people really settle in. Their hunger is gone. They will lapse into a coma, which they might come out of periodically over the next week. And then most people will die relatively peacefully within a week or 10 days. But you do need to have good palliative care, and you probably need to have hospice care as well in order to engage in the process of voluntarily stopping eating and drinking. The other thing which might be offered and provided to you, if you are suffering from uncontrollable symptoms, usually pain, but not always, is palliative sedation. When other efforts to control your symptoms and relieve your suffering have been unsuccessful. You are sedated to unconsciousness, possibly until death, but if not until death, when you might be brought out of unconsciousness just to see if your symptoms are now under control. But in any case, you will generally die, again, within a week to 2 weeks of dehydration. Dehydration is the cause of death in both situations. Okay, so I want to talk a little bit about unwanted medical care, because for too long, people have been receiving this care largely because that's what doctors do. They provide care, and nurses provide care. And if they don't know differently about your wishes, they are going to continue to provide care, even in the contrary to what you would want. And sometimes they are going to provide this care even if you've expressed your wishes. Uh, you might be resuscitated contrary to your do not resuscitate order. And we're going to talk about that. So the wishes of patients are unfortunately too often ignored. This has got to change. Think about this. 1 in 4 Americans 50 or over say that they or a family member has experienced excessive or unwanted medical treatment. A lot of people, 25 million. It's really unacceptable. And 2/3 of those surveyed said that they would withhold payments to healthcare professionals or providers who do not honor their end-of-life wishes. 4 out of 10 said they'd take legal action. And 95% of them said it was important for healthcare providers to respect their end-of-life medical wishes. Of course, they should be respecting those wishes. Doctors are not so much paternalistic now as they were 30, 40 years ago when my father was practicing medicine, although he was a wonderful, compassionate doctor. And now I think the younger breed of doctors, and more so even, I think, women doctors, are very sensitive to their patients' wishes and do comply most of the time with what their patients want. But again, there are too many people who are receiving unwanted medical care, particularly at the end of their lives. So there are certain things that can be done, which we're going to talk about, including, of course, withholding payments. And you don't have to pay for care that you don't want. And if your loved one has received excessive or unwanted care, which was clearly stated and in the healthcare record, then that care does not have to be paid for. So aggressive medical care at the end of life is widely recognized to be harmful to most cancer patients, and yet it's still being provided. I want to talk about one particular case, the case of Dr. Gerald Greenberg. In New York, he was a retired periodontist. He had Alzheimer's disease for 6 years and really was not communicating any longer. He had completed a healthcare advance directive. He appointed someone to be his healthcare agent. He had a living will. He was receiving nursing home care, and one day he was found on the floor. He was transferred to a hospital, and he was tentatively diagnosed with life-threatening sepsis. The family agreed, though, that he would not be able to regain any type of normal mental or physical function, and he was expected to survive no more than a few days without treatment, which he would not have wanted and did not want. Yet, a doctor ordered intravenous antibiotics to be given to him for 3 days, along with tests and other treatments. The family attempted to intervene, but the hospital prevented them from speaking to the prescribing doctor. The patient remained in the hospital for some weeks. He endured discomfort, suffering. Finally, he was transferred to a hospice and within a few days died. His wife was extremely angry and upset. A lawsuit was brought by Mrs. Greenberg. It failed. It failed in the lower court and it failed in the intermediate appellate court on the basis that there is no legal cause of action in New York for wrongful living. Now, we're trying to get that law changed, those decisions changed by a law a bill that I've had introduced by Assembly Member Dick Godfrey, who's the chair of the Assembly Health Committee, but the bill hasn't gone anywhere yet. In terms of cases, I know of one case that was up in our highest state court after the patient's family members had brought a lawsuit and it was dismissed, just like the Greenberg case, but it was settled for, I think, a pretty good amount of money before the case ever was argued in the State Court of Appeals. But just so you know that right now in New York, unfortunately, as opposed to other states, we do not have good case law. There is Dr. Greenberg near the end of his life. So Professor Thaddeus Pope has talked extensively about the topic of unwanted medical treatment and has written extensively as well about it. But increasingly, I think healthcare professionals are realizing that they better not provide excessive unwanted medical care or they may be sued and may be in jeopardy. In other states, there are many cases now where damages have been awarded by judges or juries after a trial when a person has been given unwanted medical care, oftentimes having been resuscitated, even in the contrary to a do not resuscitate order. There are many causes of unwanted life-sustaining treatment. Some of them Dr. Pope lists. Okay, so I want to again briefly discuss hospice because it's such a good benefit for those people who are dying. And it's really covered for the most part by commercial health insurance or under the Medicare hospice benefit. And it really does provide excellent high quality care in most instances. Virtually all communities have hospice programs. There are 42 hospices throughout New York State, and they're, from what I understand, really provide good quality service, as does Calvary, where my father-in-law died some 11 years ago now. So if you look at all the services that hospice provides, it's a pretty long list. And each of these services really can make a difference in terms of the quality of life of you or your loved one as you or your loved one is dying. But again, it's not sufficiently utilized in New York, and it's a real problem throughout the nation as well, in my view, because I think that probably 70 to 80% of those who die really should be enrolled in hospice at the time of their deaths. Okay, we've talked a little bit about palliative sedation, so I want to open it up for questions in a minute or two. I do want to say a few things about the Medical Aid in Dying Act in New York. It does now have over 50 sponsors in the Assembly and over 15 in the Senate, an increasing number of sponsors each legislative session. But unfortunately, the bill is stuck in both health committees. Why? Because The makeup of those committees with new members beginning in 2021 consists of some Democrats, as well as virtually all Republicans, who are opposed to medical aid in dying. And the chairs of those committees, Dick Godfrey in the Assembly and Gustavo Rivera in the Senate, do not have control over who sits on the health committees. So we are working diligently along with other organizations, Death with Dignity Albany, Compassionate Choices, doing a wonderful job in trying to get to legislators who are currently opposed or on the fence to try to get them to change their minds. We have had a number of meetings with some key legislators on the health committees in the past few weeks. We have others that are scheduled now in the next week or two, even though the legislative session ends next week. So nothing is going to happen during the next week in terms of getting those bills out of committee. So for those of you in Albany and if you have Assemblymember John McDonald, who's a pharmacist and a really nice guy whom we met with a couple of weeks ago, he's still not there yet. And I think he will be eventually, but please contact him. Please write him. You can go to our website, End of Life Choices, and EOLCNY.org, and find a way in which you can communicate. We have a form letter. So I'm going to stop here, except to just mention one other thing, and that is for those of you that really want to have discussions about your end of life situation, your wishes, or on behalf of a loved one, please don't hesitate to contact Judy Schwartz, who is our PhD nurse, who's our clinical director at End of Life Choices in New York. You can reach Judy at EOLCNY.org. That's Judy at EOLCNY.org or 212-252-2015. And please do visit our website. Thanks very much.
Thank you, David. So now it's time for questions. So if you have a question, please type it into the Q&A box if you have not already done so. One question was regarding the healthcare proxy form. You mentioned appointing someone that you trust to make decisions for you if you lose the ability. But what if someone doesn't have a person that they can appoint? What's the best thing that they can do to make sure their wishes are known and respected?
I personally think that the best thing a person can do is to complete a MOLST form if their healthcare provider is willing to complete the form with the patient, because it does usually encompass most everything that you might want to put in a living will or to have your healthcare agent act upon. In the absence of that, or in addition to that, you might want to complete a living will. And we do have a living will form, which particularly is for people who really don't want to have much, if any, life-sustaining treatments provided if and when they lose decision-making capacity, which is on our website. So if you go to our website and you look at advanced directives, which is on our homepage, you can get that model living will.
And what if someone completes an advance directive, but then they change their mind later? Can that be revised? What is the process like?
If you have a healthcare proxy form, for example, just complete a new healthcare proxy and your new one really supersedes the old one. Of course, better to get rid of copies of the old one if you have one. And one thing I didn't mention, but which I think is important, is that make a lot of copies of your healthcare proxy. Make sure your healthcare providers have a copy. My wife and I both have ours on our refrigerator, like you might have a do not resuscitate order. I have mine on my cell phone. My kids have my healthcare proxy on their phones. So you really want to make sure that it's going to be available. You don't want to put it in a place where it can't be easily found.
And you mentioned that sometimes their families and patients need to advocate to receive palliative care because it may not be something that's offered, even though it should be. If there's a patient or a loved one that is not receiving palliative care but thinks it would be of benefit to them, how can they go about getting palliative care or advocating to receive palliative care?
Well, the first thing I would probably do is to talk with Judy Schwartz, the clinical director of End of Life Choices New York, and ask her how she would go about trying to advocate for palliative care for the patient, given the setting and the circumstances and who are the healthcare providers. Uh, if you don't want to do that and just go about doing it yourself, then if you know who the healthcare provider is, you can contact that person directly, hopefully with the permission of the person that you're trying to help, assuming that person has decision-making capacity. And if not, uh, and if you're not the healthcare agent, you may want to talk with the person's healthcare agent.
Hmm. And to attendees, I will be sending an email out within the next few days with follow-ups to some of the things. I know David mentioned the directives that we have on our website, so I'll send links to that. And I will also include Judy's contact information. Um, One thing you mentioned with regards to receiving interventions that were against consent or were not desired, one thing that can be done is to withhold payment. But for someone who thinks that they may want to do that, I think for some there may be a fear of, what if it goes to collections? So if somebody is in a situation like that, presumably someone who lost a loved one who received unwanted care, what would your advice be to them in terms of the first steps that they could take?
If you have a lawyer, I would certainly contact that lawyer to ask him or her for advice. And if he or she does not specialize in this particular field, then ask for a referral. And if you do not have a lawyer, you might want to go to a referral service of your local county bar association for um, for uh, for advice on a case of this nature.
Hmm. We received a question. Um, the attendee said, "Thank you. I'm the same age as the president, and presumably you. Currently healthy. My daughter is a medical professional, and I trust her as my designee. We often travel together, and I wonder if I should find an alternate in case of an accident." Can you speak a little bit about when an alternate healthcare agent um, may be the designee, and how that, if someone has been listed as an alternate agent, essentially when they would become an acting agent and what might be considered when appointing someone?
Okay, first of all, I think that everyone who has a healthcare agent should also, if possible, appoint someone to be an alternate agent. And there seems to be really no limitation on the number of alternates you can have. So, for example, my wife has actually appointed um, two of her siblings to be her alternate agents. I am her agent. And so if I am not available, and this is when it comes, where an alternate comes into play, either unavailability for some reason or another. And that's usually the reason. I'm now incapacitated myself because I don't have decision-making capacity, or I'm just not reachable at a time when some healthcare decisions have to be made. And so it's really important to have someone else available, if possible, as an alternate or more than one alternate healthcare agent.
Mm. In regards to the Greenberg case, if patients have the right to refuse treatment, why is that not the primary legal question?
It should be. Um, but unfortunately, with the way the courts have looked at this is, well, if someone continues to live just because some kind of healthcare procedure or treatment was provided, uh, people in this state just don't have a cause of action, as it's called, to bring a legal claim for what is characterized as wrongful living. I think that's going to change over time. And maybe when there are a couple of cases now pending in which are going to go up to our highest state court. And when they do, I hope the Court of Appeals, which is our highest state court, will do the right thing and will change the standard for decision making in these types of cases.
Mm. We received a few questions about medical aid in dying in New York, including one from an attendee who noted that their brother took advantage of the law in California, which was a blessing for them. Where is the law at in New York right now, and what are some of the challenges that we're facing in getting it passed?
The bill, the Medical Aid in Dying Act, as it's called in New York, is in both the health committees in the Assembly and the Senate. It's unfortunately not going to get out of either of those committees during this legislative session, which adjourns next week. They come back in January. And the obstacles are, in terms of a practical obstacle, it's legislators. We don't have enough votes in either of the health committees. Unfortunately, neither the Speaker of the Assembly or the Senate Majority Leader have taken a public position on medical aid in dying. So if you want to contact anybody, including your own legislators or members of the health committees, I would urge you to contact both of them to indicate your support and to ask them to come out publicly with their support, as the governor has, as has the mayor of New York City, as has the public by almost a 2-to-1 margin in New York. The bill is supported. And by doctors, when they look at the Medical Aid in Dying Act, it's supported by a 3-to-1 margin. Other obstacles are some leadership of the disability rights community, even though most people with disabilities actually support medical aid in dying, but there are many legislators who are very sensitive, understandably, to the needs of people with disabilities and listen to those folks as they should be listened to. Unfortunately, the arguments that they raised, while once valid concerns years ago, based on the experience of having laws enacted over 20 years with 50 years of cumulative experience, has shown that their views are no longer valid as they might have once been. So we have the disability rights community, and there are also religious groups such as the New York State Catholic Conference and Orthodox Jewish groups who are opposed. And because we have some very good Catholic health systems, those healthcare systems and the New York State Catholic Conference are well respected when it comes to their views on healthcare issues. So there are some legislators who are listening to them. Some are also listening to the New York State Medical Society of the state of New York, which is opposed. Again, even though most doctors in New York are supportive, as is the New York State Academy of Family Physicians. So we have an uphill battle for a number of reasons, despite there being widespread support, both in the community and from the healthcare professionals. We are going to continue to work on it. I've been working on this bill for 6 years. I can tell from the beginning, my Assemblywoman, Amy Paulin, is the lead sponsor in the Assembly. But I can also tell you that it takes generally 5 to 10 years for bills like this to be enacted, and sometimes even longer. So as impatient as we are, we need to try to be patient.
Thank you so much, David. Unfortunately, that's all the time that we have. Before wrapping up, David, do you have any final thoughts or information you'd like to share?
I don't think so, but thank you very much for having me. Bonnie, it was great to be with you and with you, Lillian, and thank you all for attending this afternoon.
Thank you, thank you. So if we did not get a chance to answer your question, or if you think of a question later, please don't hesitate to reach out to us. I will be sending everyone a message with that email address and contact information. It's info@eolcny.org. Again, I will include that in the message that I send. We also encourage you to visit our websites, which I will include a link to. I also wanted to let you know about a couple of upcoming events that we have that may be of interest to you. Tomorrow evening, we will be hosting our second annual fundraiser, which is a Zoom-based comedy show called It Ain't No Joke, But We Could All Use a Laugh. It's more than your typical Zoom show. It's a virtual comedy club experience. We will have a great lineup of 6 comics with appearances on shows like America's Got Talent and Comedy Central. We're also going to have an MC and DJ duo to host the show and keep the festivities going, energizing the crowd. And there will also be an opportunity to win prizes and receive discounts from our sponsors. And the funds raised from the show will help address disparities by 1, normalizing conversations around end-of-life planning and care, which is important. 2, increasing accessibility to end-of-life services, and also connecting all New Yorkers with critical information about their options and rights. Also on June 14th, we will be hosting another webinar, this time on barriers to palliative care access from a Caribbean perspective. We will be joined by Dr. Leslie Reese, a Barbadian general practice and palliative care physician. I will be sending information about both of those events to you. And also, we are always adding new events to our schedule, so we encourage you to sign up for our newsletter and follow us on social media so you can stay up to date. And Bonnie, I turn it over to you to wrap up.
Thank you, Lillian, and thank you, David, so much for sharing such a wealth of information. You know, I've heard this many times from you and from other speakers, and I still learn something every time I hear it. So thank you very much. And thanks to Lillian for managing the technical aspects of all of this webinar and the communication so expertly and seamlessly. We do miss seeing you in person, and although there are a lot of advantages to doing the webinars online, but nothing beats seeing you in person, and we certainly hope it becomes safe enough soon for us to gather in person and see each other. Thank you all, and have a good summer.